And one, we are live.
A very good evening, everyone. I am Dr. Hriday Acharya, and I'd like to welcome you all to the next edition of the Pediatric Spine Academy webinars. Pediatric Spine Academy, as we already know, is a non-profit organization which is aimed at spreading knowledge and educational activities regarding pediatric spine anomalies. Now, this time around, we have the webinar based on bracing in scoliosis, and I'd like to invite Dr. Arjun Dhawale, a pediatric spine surgeon from Mumbai, to host this webinar. Over to Dr. Arjun Dhawale.
Hello, everybody. It's our pleasure to have all the esteemed faculty for this meeting. And Dr. K V Menon is going to be speaking to us about the current role of bracing in idiopathic scoliosis. And we have Dr. Rigo, who is a world-renowned authority with the Rigo brace, who will be talking to us about his brace and the indications for that. Now, bracing for scoliosis is probably one of the greatest treatments described, because it is a treatment which requires no surgery and no fusion, and which can correct scoliosis, if it's picked up on time, and the patient can have normal function, and a normal life. And the greatness of the treatment is the simplicity of it. Although we as surgeons would like to do surgeries, and correct spinal deformities, there is no greater treatment than bracing, and this has, been proved beyond doubt by the brace study by Stuart Weinstein. And I will like to hand over to Dr. K V Menon, who is a renowned authority, professor of orthopedics, who currently is working at Rajgiri Hospital, has formerly been professor at AIIMS, Kochi, and at Bharatiya Vidyapeeth, and has been the chair of the AO Spine Asia Pacific, and conducts the Scoli Week every year with Dr. Nene. Thank you, sir.
Thank you very much. Can you hear me now?
Yes, sir.
Okay. Shall I share my screen? Is that visible? Arjun, can you see my first slide?
Yes, very visible, KB.
Okay, so I'll take about 10-15 minutes. I'll just run you through the principles of bracing for AIS, and this will be a general overview before Professor Rigo comes in, okay? I don't have any disclosures. In this lecture, I'll run you through the history of bracing, the types of braces that we have available, a little bit about the scoliosis classification that brace makers use, which is vastly different from the ones that we surgeons use, the modern indications of bracing, and the biomechanical principles involved, and some of the outcomes of bracing from recent literature before I summarize this talk. Why do I want to talk about history? I think history is important largely to prevent, to kind of subdue the temptation that we might have to reinvent the wheel. If you look at the history itself, you'll realize, besides the anthological value that it has, you'll realize that when you look at modern bracing and you look at the principles of convex apical pressure, the biomechanical principles, which are the 3-point pressure and things like that, you think that's something really new. But when you look back at the history, you find that everything was discovered at least 2 or 3 centuries ago. People knew these principles several centuries ago, and they were working on 3-point bending and apical pressure and things like that. When you look at modern traction devices, we use all these modern traction devices for very large, very stiff curves, but it really isn't new. It was known hundreds of years back. And from the time of Hippocrates, all these principles were known to us. It's just that they didn't have the modern mechanics, the modern machines, the modern devices that we have. They didn't have the safety networks that we have in today's medical practice to implement it successfully at that time. Even the compression distraction device, which is this turnbuckle cast, which was described in 1924, exactly 100 years ago. That's when this device was described, and we still tend to use variations of this device in modern surgical practice. We think that the spine core device is very new, absolutely just about a decade old, and this is considered the best of the modern flexible braces. Well, it was actually described in 1876. It's just that they didn't have the technology to do it. They didn't have the technology to spread it worldwide like we have today. The first of the braces were described for trauma in the 1500s. The first of the scoliosis braces were described in the 1800s. But the real change came in 1940s with Blount and Schmidt describing the Milwaukee brace. The Milwaukee brace was, at that time, the gold standard, was the first successful brace that was used for scoliosis. And that's one of the first publications that they made in 1958 in the JBJS American at that time. But the problem with the Milwaukee brace was it's a very large profile brace. It's a very loud brace with a neck piece. It's got a large metallic component at the back, and virtually everything about it sticks out, and children had a bad time wearing it. The compliance was very low at that time. We tried in 86 to 88, 89 for about 3 years, 4 years that I was working in a scoliosis unit. I started the Milwaukee brace. In my part of India, the compliance was zero. So none of the girls would go to school wearing that brace. Fortunately for us, McEwen in 69 developed the Wilmington brace, which was the first low-profile brace. It was a thermoplastic brace. It also followed the same principles: convex, apex, compression, three-point pressure, apical rotation, pads inside, etc., etc. And this was good news for us. Till 1972, when John Hall and his team developed the Boston brace. Now, currently, what is described as the gold standard, at least for North America, is the Boston brace. Perhaps in Europe, it isn't so. It's probably the Chenou brace, but yet the Boston brace for many years is considered, was for many of us in different parts of the world, is considered the gold standard. It came with different components which you could, they are prefabricated modules which you could assemble and use for individual cases. Charleston in 79 described the Charleston brace, which was a part-time brace, and this made a huge difference because children did not have to wear a brace for 23 hours. Most of the other braces which are described are worn for 23 hours, except for the part-time braces like the Charleston. And in 98, from Montreal in Quebec, they described the use of the spine core brace, and several other of the newer braces started thereafter. I think we will be hearing a lot about the Scoliosis Research Society and the newer organization, the SOSOT. The Scoliosis Research Society, we are all familiar with because many of us are members of that. We are involved as surgeons. We are involved in scoliosis research activities, but we are less familiar with the SOSOT. The SOSOT is an organization that was based on the non-operative care for scoliosis and the rehabilitation of scoliosis patients. This was established in 2005, and we are going to be privileged today to hear one of the founders and the founder president, Professor Manuel Rigo, speak to us immediately after my talk. So we will wait to hear him. If you look at the references given at the bottom, the orthotic principles that were used in deformity orthosis at that time were formed by Winter, John Lonston, etc., etc. And these authors told us that scoliosis braces does not really offer any correction. It is only to prevent progression of deformity. And before you start a scoliosis orthosis, you must get at least 50% correctability in the brace. But the one thing that was good about it was that independent of the remaining growth, you could achieve some stabilization of the curve. You could prevent the progression of the curve. James Roach, in 1994, I have met him and read his papers about scoliosis bracing. So he defined the indications of bracing as broadly twofold. One was the primary treatment of AIS, and the second was in postoperative issues. Now, we have experience with both the primary treatment of AIS as well as the treatment of post-operative, but I'm going to emphasize on the latter part of it because the former part of it you're going to hear from Professor Rigo in a minute. So the theory then was that you could if you read through the first 4 indications, you'll realize that it could be any reserve grade. It's reserve 0 to 4 or 5 in boys. It could be any degree up to 40 degrees, 20 to 40 degrees. Below 20 degrees, you normally tend to just observe. So 20 to 40 degree, any reserve grade, you could use it. But the post-operative indication, which I'm going to emphasize on, is decompensation occurring after surgery. Compensatory curve whenever you do a selective thoracic fusion and you develop a problem thereafter, and if you have a not too rigid construct, which was happening in our previous construct when we were not using all screw constructs. I'm going to give you an example here. This child was operated by me several years ago. We did an anterior surgery, which we thought was very good, but post-operatively, you can see that the curve is looking very ugly. Her body shape is not very balanced at all. So we put her into a brace at that time. And that's the kind of post-operative image that we have achieved, post-bracing image that we have achieved. In the brace, you can see that the balance is restored. So this is one of the indications of brace that we use for post-operative care. Here's the second one. This is actually a Lenke 6 curve, but we failed to diagnose it appropriately. We thought it was a Lenke 5, and we fused the lumbar spine anteriorly. Post-operatively, the thoracic spine decompensated. And in this is another indication when you select a limited fusion technique and the other curve, the compensatory curve, decompensates, and then you would choose. Similarly, this is a thoracic curve which has been selected for selective thoracic fusion. And after the thoracic fusion has been done, the lumbar curve is decompensated. This is perhaps another indication for fusion, for bracing. The other thing, for many, many years in the early 90s and up to perhaps the beginning of 20s, we were using hybrid constructs because we did not have the know-how for all screw constructs, where we were using pedicle screws at the bottom for the foundation. We were using sublaminar wires in the middle or hooks in the middle, and the main part, the top part of the construct was hooks. Now, this type of a construct is not a very firm or rigid construct, and at that time, we were using post-operative bracing for, let's say, 3 to 6 months till the fusion was solid. So these are the indications for bracing in the post-operative context. Now, I'll move on to the other part of the talk, which is about classification of orthosis. You might hear other classifications, but the traditional classification is that they are ambulatory braces or the recumbent braces. The ambulatory braces are to be worn for 20 to 23 hours per day. They are again in 2 categories: the rigid braces, where you have the Milwaukee, Boston, Wilmington, Miami, and of course the European braces, the Chenou, etc. And the flexible braces are the Triac and the spine core braces, which allow some amount of mobility, which allows the children to go around and play, probably not participate in gymnastics, but at least keep themselves mobile and active. The other group is the recumbent braces, which are worn for roughly 8 hours when the child is sleeping or in bed. And they are the classic examples of the Charleston and the Providence brace. So this is, so I'm just showing you some pictures. The Boston brace is what is currently considered the gold standard for North American braces, and in many parts of Asia, we use that. The Lyon brace was one of the first, the oldest French brace, which still had the rigid uprights, which the Milwaukee brace had. But the Chenou is really where the modern European braces started, and you're going to hear more about it from Professor Rigo in a minute. When the Chenou brace started, they were collaborating with some of the German surgeons. So it was called the CTN brace, the Chenou Toulon Munster brace, but then that has now become the Chenou Rigo brace. And the modern brace is called the Chenou Jensingen brace. So you'll hear more about this in the next few minutes. There are a lot of new flexible braces. When I said new, I also mentioned in the beginning of the talk, they're not really new. They're about 200 years old, or maybe more, 300 years old. You have this concept of using elastic bands with a few rigid segments, but most of it is elastic bands. These type of braces, like the spine core brace, allows some mobility. It can be used at a younger age group because it doesn't restrict activity, and it can also be used for the upper thoracic curve, or so the authors of those papers say. You also have a similar brace called the Triac brace. The Triac has now come up with a second generation of Triac brace, which is using computer CAD/CAM design. They generate a whole body, a three-dimensional image of the body, and fix the brace onto the three-dimensional image and work out the biomechanics of the brace before they actually or fix it onto the patient's body itself. The recumbent bracings, the Charleston brace, which was the first of the recumbent bracing, is basically a TLSO type of orthosis, which is a convex side bending brace. And we have experimented with this quite a bit in the early and late, up to the mid 90s. We were working on these braces, and they do work well in selected situations. The Providence brace is a little more advanced form of that. You need a computer CAD/CAM design to design these braces and apply them. So in 2004, when we first started working on our retrospective series of braces, we looked at 84 cases. Jayashree was my orthotist at that time, and we looked at these results. We were looking at a Charleston type of convex side bending brace with some padding inside. It wasn't a very advanced design or anything. It wasn't what I would call biomechanically one of those high-tech braces, but we found that some good things came out of it. We found that if you have a thoracolumbar or a lumbar curve which is less than 40 degrees, which is reasonably flexible up to, let's say, 50% flexible, vast majority of them could avoid surgery, which was the good news. But if you had a thoracic curve or a Lenke type 1 curve, or even a type 2 curve, those curves would not work very well with this type of a convex side bending brace. The advantage in our climate, in our country, which is a very hot country and a very humid country, children had to wear it only for about 8 hours. They didn't have to wear it to school, which was a grateful thing. And the compliance was, at least in our part of the country, it was close to 100%, where our Milwaukee experience was abysmal. Milwaukee brace wearing was just about close to zero. So these are some examples from our bracing study. We found that these type of curves, if you have a thoracolumbar apex or a single curve, and these tended to work quite well. Now we come to the classification of scoliosis based on the bracing principles. So the first of the classifications was developed by Chenu. Chenu's concept was very simple. He said that you either have a 3-curve or a 4-curve type of curves. What it means is, in surgical parlors, it means that you either have a single curve type of scoliosis or a double curve scoliosis with 2 compensatories above and below. For surgeons, we understand compensatories above and below, which are non-structural curves. And that's what it meant. The Schroth system, which came out of Germany, they modified this Chenu's principle, and they modified into another set. You're going to hear the Rigo-Weiss modification of this, which involves several other subtypes. I understand the Rigo's original classification had 4 subtypes, and now it is 5 subtypes. What I read is that. But unlike the classifications that we surgeons use, there's something very remarkable about the classification that the rehabilitation people and the brace making orthotist people, they use. All of us are familiar with the Lenke, King, PUMC, Ponseti, Elsevier, all the scoliosis classification that we use, and we tend to use it only for one reason: to select the fusion levels. We want to know which is your upper instrumented vertebra, which is your lower instrumented vertebra, how many screws to put, how to cluster your screws, put your screws near the apex, and then correct the curve. This is what our concept is all about. We have very little concept about pelvic or spinal balance. We have very little concept about the axial plane, which is probably the single most crucial plane in scoliosis, according to me. That is what it is. And we tend to depend so much on the curve location, the curve degree, the curve flexibility, what is the structurality of the curve, and some of those absolutely mundane things, in my opinion, mundane things like last touch vertebra and last substantially touched vertebra. Why do I say mundane? Because if you move a millimeter to the one side when you're standing while taking this X-ray, the last substantially touched or the touched vertebra could shift. So obviously, they do not have a great deal of value in terms of determining the structural principles or the biomechanical principles of that curve. Whereas if you look at the Rigo, the Shenyu type of classification, it looks at the T1 in relation to the CSVL. It looks at the TP or the transition point in relation to the CSVL. It looks at the L4 in relation to the CSVL. And why is this important? This is crucial because if you look at the T1 and understand whether it is on, look at the first picture on the left, the clinical photograph. Is it on the convex side of the curve or the concave side of the curve determines what is the position of the neck in relation to the trunk. Similarly, if you look at the transition point in relation to the CSVL, that tells you where the foundation is going to be, where your entire correction forces are going to be neutralized on the curve above and the curve below. Similarly, if you look at the L4, the station of the L4 in relation to the CSVL, that whether it's on the convex side or the concave side, that tells you what is the relationship of the trunk with the pelvis. And these are crucial points in terms of balancing and crucial points in terms of correcting biomechanical principles of correcting that curve. And that's why I say these classifications, to my mind, are far more scientific and logical than the surgical classifications that we use in our everyday practice, which determine just the fusion level, the upper end vertebra, the lower end vertebra, and last touch vertebra and last substantially touch vertebra. So modern bracing, what we're going to hear now, is a very highly technically advanced concept, and they are classification based, whether you use the Shenyu, the Rigo, the modified Rigo, or the Schroth, and it requires specialized training. You have to visit one of their institutes, sit with them, live with them, learn with them, and only then can you practice these principles. And they use modern CAD/CAM designs for fabrication of their braces. This is from the Providence brace CAD/CAM design structure. They create a three-dimensional structure for the brace, for the trunk, and they decide where the pressure points are meant to be. Similarly, in today's world, we don't have this technology in many places in India, barring AIIMS in Delhi, where they use the EOS. The EOS is capable of simulating the three-dimensional shape of the trunk, and based on that trunk, on that simulation, it would tell us where the bracing pressure points are to be designed. Now, this is one of the most important concepts that the EOS has given us. That's called the PMC, or the plane of maximum curvature. If you look at a three-curve classification, which Rigo was talking about, you will find that each scoliosis curve has got a main thoracic curve. There's a compensatory curve above and a compensatory curve below. And each of them, if you look at the apical vertebra in the coronal plane, the apical vertebrae, if you look at the far right image at the bottom, is translated and directed towards a different direction. If you look at it from the top like this, if you look at that curve from the top like this, you'll find the apical vertebra of the main thoracic curve, the proximal thoracic curve, and the thoracolumbar curve are all facing in different directions. And that is called the plane of maximum curvature. Understanding this is crucial for bracing. Understanding this, I believe, is crucial for surgical correction also, because if you need to correct it, you just have to identify where that wedge is displaced, and you push the wedge back in the direction of the plane of maximum curvature, and you will achieve your correction, whether it's done with a brace, whether it's done with surgery, whether it's done with some other technology. You will be able to achieve that. Whether it's done with specialized exercises to push that wedge back, you will achieve the same. This, I believe, is the basic principle of using the EOS and identifying the plane of maximum curvature. Lastly, about outcomes in bracing. John Moe in 1974, he actually pushed for the school screening program in North America. Why did he push for that? Because he believed, and his team in North America believed, that bracing was effective. So you had to identify the kids with minimal scoliosis very early, put them to a bracing program, and then it'll all work. But within 10 years, within a decade, the first publication started appearing in 1984. The Canadians came out with this publication that bracing is not all that effective. So you know what? School screening program should be abandoned. So in another 2 decades, in 2004, the US Preventive Task Force made a recommendation that you don't need school screening anymore. There are other reasons also besides this. The cost effectiveness part of it was also there. But the main reason of it was that they found that bracing was not very effective. So in about 3 decades time, since the time bracing started, it was abandoned in the US. And you'll see that from the following publications in 2007 or so, in many parts of Europe also, they abandoned the school screening program because bracing was ineffective. Till 2013, that's another decade down the line, when they came up with the braced trial. This was a remarkable trial by Stuart Weinstein and his team, when they studied a large number of patients, and they found that bracing is superior to observation. And this was a prospectively conducted randomized trial, very well conducted trial. And depending on the time the brace is worn, they have excellent results with bracing. And in terms of reducing the need for surgery, bracing was definitely a very important factor. They did not look at scoliosis-specific exercises, but in that study, they were looking only at bracing, and they found that it is definitely superior to observation. So this is the new evidence, but there's lots of other evidence also. Rigo and Weiss themselves have published their first publication in relation to bracing was this. That compared to the non-intervention group, the need for surgery was substantially reduced. There were other publications. The second publication that I've quoted is a 2023 publication, which also looks at the Chenot brace, which has substantially reduced the need for surgery. So there's a lot of evidence coming out of literature there, because the previous brace studies were all not prospectively conducted, not well conducted, not randomized, not controlled. So now we have lots of studies coming out which are prospective, randomized, and controlled trials, which are showing that braces, if designed appropriately, can be very effective, at least in terms of reducing the number of patients that would eventually need surgery. Yes, braces do have some disadvantages. Some of the braces are high profile. They are cosmetically unacceptable to some of the children. Many of the children are girls. Most of them are, in fact, girls, and they do have a problem with wearing these to school. Compliance is therefore an issue. Monitoring compliance is also an issue. Some of the braces can be psychologically handicapping because patients, girls and even boys going to school, do get a low self-esteem because they're wearing the brace. Physical activities are somewhat restricted in the 23-24-hour brace wearing regimes. There are some pulmonary function and even renal dysfunction which have been described. Pressure sores can sometimes occur. Secondary deformity is also been recorded with brace. You wear a brace and you correct the primary curve, but you develop another curve above or below that. So all these kinds of problems have been described. But nonetheless, we now have definitive evidence that brace wearing does make a difference. It can reduce the number of patients who will eventually land up in surgery. So the summary of what I've been trying to tell you in the last 15 minutes or 18 minutes is that bracing has got two indications. One is indicated in preventing progression of flexible curves up to 40 degrees. It is also used in selected cases of postoperative decompensation, things like that. Braces are broadly ambulatory or recumbent brace, flexible or rigid. Boston at one time was the gold standard, but it needs to be worn for 23 hours. You're going to hear about the Chenot brace, which is the European gold standard. Recumbent braces are typically worn for roughly about 8 hours. Bracing has to be a very precise scientific thing. It's not a very random thing. You can't make a TLSO brace and hope that it'll work for scoliosis. It doesn't. You can't wear a trauma brace and hope that it'll work for scoliosis. It doesn't. And braces typically have to be worn till patients are Risser grade 4 in females and 5 in males. There are some limited disadvantages, but we need to be cautious about the disadvantages of bracing. There's a psychological impact. There's some lung function to be monitored periodically, skin issues that have been monitored, and there can be some activity limitations. So exercise therapy, specifically scoliosis-specific therapy, is specifically effective, but other exercises can also help these patients wear the braces more effectively. Thank you for your attention.
Okay, I think Dr. Rigo, we're ready for you to go ahead.
Okay, so can I share my screen? Have I permission for that? Yeah. Let's see.
Yes, please.
Okay. So thank you very much for your invitation to participate in this webinar. I have enjoyed very much your presentation, Professor. So Now I'm going to talk a little bit about this brace concept that you have been telling is the gold standard in Europe. Okay, so the Rigo bracing concept is really based on the original Chenu concept, and this is what I want to explain here. Obviously, half an hour is not time enough to go very deep on the details of this brace construction, but I will try to emphasize more the main principles. Okay. Let's see. So in our daily clinical practice, results of bracing depends on several factors. It depends on the doctor decisions, it depends on the patient, and it depends on the brace. Of course, it's necessary to make good decisions and to have a good brace, all oriented to the patient, but there are also some factors depending on the patient, like the flexibility, the type of response, the compliance, and the fact that patients are following a program of physiotherapy or not. So the first thing we need really is to define some realistic expectations about bracing, because nowadays you know that by Google, people find a lot of, let's say, wrong information about what a brace can do. So the main objective of bracing is first preventing progression beyond the threshold for surgery, then preventing progression or stabilizing the curvature that we are starting to treat, meaning 5 degrees up or down. These two objectives are quite supported by the evidence that this is possible to do that. Then you have a more ambitious objective, which could be getting a long-term partial correction. Partial correction has been reported in some papers. And it's also possible to use the brace in major curvatures when operation is rejected or contraindicated for any reason, if there is no any specific contraindication that I will say later. So we know now that bracing works, but can we do it better? That's the main questions. And this is about selecting better our patients. And for that, we would need ideally to have a predictor factor for progression and also a predictive factor for responders, and then designing better braces. This is something we really would like to do. So in terms of talking about indications, when you look at the last consensus paper of the SRS together with the SOSOR, you find that the bracing indications are very wide, very general. It said that no role for bracing in curves less than 15 or over 60. So is taking the cup angle as the, let's say, the criteria to decide whether to brace or not to brace. No role shoe for patients that are mature. And then the brace prescription, there was a consensus about using rigid braces against, let's say, flexible braces or so. And the consensus was also about full-time bracing for patients on the high risk for surgery. And full-time bracing was defined as wearing the brace 18 hours or more. Also for the European braces, for the Chenu concept, the threshold has been established in 20 hours. 20 hours up and 20 hours down, the results are significantly different. And also this consensus paper emphasized about the primary goal of bracing therapy is to prevent or limit poor progression, including progression to surgery. Let me see if I can go forward. So if you take these wide indications, very general, you could more or less design a protocol about that. And there is some, let's say, consensus also about the first indication for bracing is when scoliosis goes 25 degrees or up in a risky period of growth. Let's define this risky period, the main risky period from the starting puberty, taking the passing the peak of growth till research 2. So probably full-time braces is indicated when the scoliosis is over 25 degrees, 25 or over 25 degrees. And after research 2, when the scoliosis goes over 25, I think this this point was taken from considering scoliosis during growth, measuring 30 degrees to be definable as progressing scoliosis and taking the error of measurement plus minus 5 degrees. So we take 25. This has been a classical thing in bracing. So for those patients by Richard 2 or beyond, the partial time indication of the brace, 12 to 20 hours or nighttime brace, could be also a good indication. However, there applying this protocol, you are still under the risk of over-treating or under-treating. This is an example of a girl who progressed from the initial X-ray to the second X-ray to 25 degrees when she was Richard 2. And it was suggested at that time to wear a brace, but the patient disappeared from the consultation and came back again around 1 year later when she was already Richard 3 and Sanders 7, and she had exactly the same degree, 25. So this girl didn't progress, even having a scoliosis, which could be, according to the protocol under the prescription of bracing, the recommendation for bracing. In this case, the brace would be an over-treatment because the girl has a non-progressive scoliosis. So it's essential for us more and more and more. We are asking the researchers for us to give us a predictor of progression. And there has been some trials using 3D phenotypes or using biomarkers or using machine learning algorithms or things like this, or also looking at the phenotypes of the microarchitecture of the bones. So these two last papers have been presented in Barcelona during the SRS meeting last week or 2 weeks ago. And this is very important, but still we cannot use this in our daily clinical set because this is not still available and has not been validated. The second point is the responders. We have seen all good responders. This is a girl finishing with a residual curvature of 10 degrees after starting at 9 years of age with a scoliosis 31 degrees and having the best in brace correction in her second brace. You see she was 7 degrees, well balanced, no compensations. So this is a good responder. And good responders have been also related to some phenotypes and also to patients with correct levels of vitamin D. So besides to that, we know that flexible curvatures are better responding than scoliosis that are more rigid. So talking about now the quality of the braces, the SOSOR together with the SRS, the ISPO and POSNA presented this paper describing many different type of braces. And the problem is that the name of the brace is not guaranteeing any result. The important thing is how good is the design of the brace according to any concept. So it's not about name of braces, but it's something about the type of brace. And you have very simplistically here, you have three possibilities. You have a good brace, you have an neutral brace doing not good, not bad, and then you have a bad brace with iatrogenic effect, which is something very dangerous. This is the paradigm of the scoliosis treatment with a brace. Sometimes a bad brace like this is just an inelective tube pushing the body in a wrong way because the concavity of the curvature is clearly collapsed. But this girl was not showing further progression. So even with a bad brace, if you are treating a non-progressive scoliosis, you can get a good result, no progression. So it's very difficult to understand whether this brace was good or bad for somebody who is not really very familiarized with the brace action. Another brace here, you see, this was made under the name of Chenu brace, made with CAD-CAM. CAD-CAM is a good system, but it's not guaranteeing by itself the result of the treatment because this brace was wrong for the curve pattern of this girl. She got too much pressure on the left side, so the pressure was even collapsing also the thoracic concavity, and you see how in-brace correction is not there, but contrary, there was a deterioration in the brace, and the girl showed 1 year later progression to 50 degrees. still showing the original curve pattern. So it's clear that this change in the geometry of the spine was produced by a wrong brace. So no matter the name, you can have a good brace or a bad brace. The only way that we have probably now is the only way we have to check the brace quality is the in-brace correction. So we listen, and it's right that the in-brace correction is predicting the end result, and the 50% in-brace correction is defined as excellent, but not all the patients can accept 50% of correction, because it depends also on the patient, flexibility, and other factors. So the myth of the 50% in-brace correction has to be finally overcame, because it's not only about the brace quality, it's also about the patient quality. So rigidity, curve, pattern, gender, morphology, these could define whether scoliosis can be more or less corrected. So we have, even with the best brace, some limitations. Talking about patient morphology, high BMI, low BMI, and depending on which endophenotypes are limitations. Also, rigidity associated with soft tissue or associated with a high degree of intravertebral torsion. So a scoliosis, which is very structural, is also a limitation. What about the cup angle? I don't think that the cup angle is such a good factor for limiting brace action. I mean, sometimes you could have a scoliosis measuring 60 degrees, that is single curvature with a very low degree of intravertebral torsion and high flexibility that can still be managed if the patient is rejecting or surgery is contraindicated for any reason. Then we need the commitment for compliance. Compliance, of course, is one of the most relevant factors for good end result. And then you have the limitation of syndromic and secondary scoliosis. Besides that, we have also clear contraindications. What the scoliosis is progressing into a point that the lordotization of the thoracic spine is deforming the body, the thorax, as with the shape that you observe here, is like a boomerang. No matter where you put your pads here, what you are going to do is to increase the flat back, to increase the lordotization and deform more the ribs. So the real contraindication for bracing is not a high cup angle, but is the a strong torsional phenomenon suffered by the spine, especially when the curvature goes up over 45, 50 degrees, and then is associated to let's say, a big flat back phenomenon, a lordotization. So also the SRS could give you permission to brace a patient with the scoliosis 51 degrees like you see here. In this case, I think that bracing with this angular rib hum and this lordotization of the thoracic spine was contraindicated, because this rib shape is really a contraindication. No matter where you put your pad, this is going to increase and the flat back phenomenon is going to progress. So probably we should define the contraindications by using other parameters than the cup angle, like for example, the intra spine hump. So the index of the spine protruding into the thorax. This would be a better factor probably to define contraindications. Now, this is why I am really questioning the let's say this consensus about defining the use of the brace according to the cup angle. I think we should really look for different factors. Now, what about the brace? This brace concept defined sometimes as a Rigo concept bracing, Rigo Chenu brace, or similar names. It's a custom monovalve ventral open rigid thermoplastic brace. And the important thing is that the mechanisms of correction, or call it the principles, it's 3D correction by the torsion, using the torsion. This brace was inspired in the Chenu concept. Chenu was introducing his concept in 1979 together with Professor Matthias in some meeting celebrated in the old Czechoslovakia. And the idea of Chenu was trying to reproduce with a plastic brace the principles of casting. So his masters were Cottrell, Estañara, and Abbott. Abbott, he was not living at the time of Abbott, but he was paying attention to what Abbott explained. And that was based on principles called three-point system, the rotation, etc. So the point is that this is an external asymmetric design in constant evolution from 1979, from low to high asymmetry. And there are too many versions and divergent derivatives, which is producing a poor standard. So you can see here patients with the same curve pattern and using the same name in their braces. All these braces were built under the name of Chenu. You see how different are the brace designs. So where is the standard here? We have not. And the reason for that is that this is a very, let's say, sophisticated technique to correct, which look for the fabrication of contact or paths, which are located, shaped, and oriented to provide 3D correction according to the curve pattern and the trunk morphology. And it also has some expansion rooms allowing tissue migration, growth, and breathing. So no matter the type of curve, for every type of curve, you have a very well-established technical procedure in the correction of the mouth. So the patients are scanned, then you get a mouth of the patient. You first align the mouth in the frontal, in the sagittal, and the transversal plane. And once you have made this alignment together with an elongation of the mouth, then you design the areas where the contacts are going to work, and you define also the shape and the orientation of these areas. And then finally, you build the expansion rooms by adding a lot of plaster, as you can see here. So this is a very complex procedure, as also it's very well described, it's complex, and it needs really experience from the brace maker to get a good result. So my main contribution during the last 20 years has been about a task for standardization, and this was about educating orthotists in the understanding about the 3D nature of scoliosis, describing well the specific principle of correction of this type of brace, and some predefined strategies of correction correlating with the classification. So the classification is important, but it's not all. You need also a lot of experience to build this brace. About three dimensions, we all know that the scoliosis is a three-dimensional deformity with three components: lateral deviation, rotation, and anterior overgrowth, which are all couplet. And this couplet is only explainable by defining a scoliosis as a torsion. So as a torsion of the spine. So scoliosis comes from a torsion. Most of the scoliosis, not all, comes from a torsional mechanism. And this term has been really very much used by the popular French surgeon Jean de Bosset. He described scoliosis to be a torsion, but the first one in the modern era was Pediatric, describing scoliosis as a torsion. Also, this is very old indeed. Dubosset, talking about scoliosis being a torsion, define a general principle of correction, which would be reaching the best possible frontal and sagittal plane alignment throughout the torsional forces with no traction. So this is a general principle of scoliosis correction. But this is, again, not new, because you see this picture from the Adams book in the 19th century. Adams was already talking about the lordotization of the thoracic spine, and was also introducing some rotation braces, or the rotation braces. So the rotation is a very important component of the torsional force. But we know all, especially surgeons, that the rotation is related to lordotization of the thoracic spine. And also in bracing, this has been described by the group of Labelle, Carl Cobin, and some other authors. So the idea here is that when you apply a force from the back to the front on the thoracic convexity, for example, taking here this example of a single thoracic structural curvature, when you do the rotation, what you do normally is that you bring the lordotization of the spine into the middle sagittal plane. And at the end of the day, if you were correcting fully the spine by derotating, this is the effect that you would get on the sagittal shape of the spine. Of course, this global extension is not compatible with the sagittal balance, so the patient needs to do kyphotizing compensations up and down this lordotization. But this is not a lordotization created by the procedure, by the surgery, or by the brace. This is only the fact that when you derotate, you bring the plane of maximum deformity from one angle to practically zero angle if you derotate fully. And that means that when derotating, you bring the lordotization of the spine into the middle sagittal plane. So it's important not to produce this effect. And the only theoretical way you would, by detorsion, you could control the sagittal geometry of the spine would be by means of internal forces acting in front of the spine. So this is something that a brace cannot do. Maybe surgery can do, but a brace cannot do. And those orthotists thinking that the correction of the scoliosis is based on derotation and three-point system working in the frontal plane, but also three-point system working in the sagittal plane to recreate, to produce again thoracic kyphosis. This is an illusion. It cannot work because the brace is not acting directly in front of the spine, but is acting through the rib cage, and it's not possible to do that because if you push the rib cage back with this third point here, the only thing you get is a bending effect in the sagittal plane with increase of the compensatory kyphotizations up and down the lordotic area, and you decrease the sagittal diameter of the thorax, which is probably not a good idea. So those following this idea, we have to prevent by correcting scoliosis in frontal or transversal plane. We have to prevent the lordotization, or we have to correct the flat back phenomenon. Many orthotists are following the indications from Labelle groups about correcting scoliosis through lateral pressure on the convexity, establishing a stopping point back on the rib hump, and pushing in front in the ventral rib hump. But the problem of this approach is that when you design a brace which is pushing in front and pushing laterally on the thoracic convexity, when you have a scoliosis with high risk of progression from the torsional phenomenon, what used to do this brace is to deform the ribs and produce an angular rib shape. And on the other side, having room on the left, it allowed this thoracic spine being deformed to translate, to escape to this room. And the effect at the end is that the scoliosis tend equally to progress even more. So this type of brace is facilitating the progression of the scoliosis as a torsional phenomenon. You are angulating more the ribs, deforming the rib cage, and also this is associated because is produced this strong lateral force, a bending effect on the trunk. This is very much associated to the iatrogenic secondary proximal thoracic curvature, like you can see in this case, where the scoliosis was corrected too much. The degree of correction was too much for what this scoliosis was accepting, and this correction was created by bending, and this produced the iatrogenic proximal curvature. So this is not new. From casting, we know about bending works only in really single scoliosis, very flexible. This case, you could use bending correction, but in most of the scoliosis progressing as a torsional phenomenon, you cannot do bending because then you create always the proximal thoracic curvature. So the idea would be to correct by getting a good coronal balance, not producing bending. And of course, when you use casting, due to the discomfort of this point on the left axilla, the left shoulder was going up, but it's not the same this shoulder imbalance produced by bending that this shoulder imbalance created by the discomfort of the pad. Besides to that, you can see that this cast has no any point in front of the thorax on this point. So masters of casting were controlling the flat back, and rotation, not by using a contact in front, but they were using a stopping point in the back, and they were using their hands, pushing from a lateral medial, ventrolateral direction to dorsomedial direction. So they were pushing exactly on that direction, not really to the back. And this is what Chenou observed, and he had the idea of the brace being built by two contacts, one in the back right and other one for right thoracic in the front left, two contacts which should be designed to reduce the major oblique diameter of the deformed thorax. So the idea was reshaping and restoring the rib cage to get the control of the flat back. So you see that the pressure is not going ventral to dorsal, but is going on this oblique direction. And the dorsal pad is offering a stopping point in the back, and there is not a strong lateral pressure. So the whole rib cage is translated into the correct frontal plane alignment, but there is no strong lateral pressure to produce this effect. And this was the same for casting. In casting, you were using bands for their rotation, and then the hand was pushing on this direction, not on that direction, to reduce this oblique diameter. So this is the effect of casting: the rotation, from the dorsal band, and then the hand push it on this direction to reshape the thorax and get from this reshaping a better control of the lordotization by increasing also the sagittal diameter. At the time you reduce this diameter and you increase this one, the sagittal diameter of the thorax increase. And this is the main principle of the so-called Chenou technique, and that I have been describing using biomechanical concepts like this. So this would be the effect of the brace in the thoracic region, reshaping the thorax, and through this reshaping the thorax and leaving the convenient room in the back and in the front, every breathing movement is going to produce an increase of the sagittal diameter of the thorax. And this increase of the sagittal diameter of the thorax is what is fighting against the lordotization, the flat back. Still, if you try to correct too much, you can produce, of course, the flat back. So it's about correcting the best you can, not the maximum. The objective is not maximum correction, but the best possible correction, not increasing the flat back and not producing compensations. At the end of the day, you cannot apply the rotational effect and this reshaping effect on the thorax if you don't open the thoracic concavity. If you don't decollapse this concavity, it's impossible to get this effect. So you use elongation and three-point system working in the frontal plane to get this decollapse of the thoracic concavity in order to be able to produce this reshaping effect on the thorax. This is an example of scoliosis treated with a brace under the name of Rigo. The first trial was insufficient. The correction was less than expected for the flexibility of the curvature. And the temptation of many doctors would be here, so let's put more pressure. And putting more pressure in a short brace, which is not getting the correct elongation, normally will produce an overcorrection of the thoracic curvature, but the promotion of the compensatory proximal curvature, which has the risk to go into progression. So you can get a good balance looking at the T1 and all the transitions, the upper transition, the lower transition, what we call the transitional point, by using this principle of elongation, three-point system, and the rotation. All together, we could call it the torsion. And this is the objective in the frontal plane, to get the best possible correction of the curvature, also rotation, and still maintaining a good balance and not creating compensations. While in the sagittal plane, the objective would be to get the best possible sacral slope, pelvic tilt, and maximal lumbar lordosis in relationship with the PI of the patient. So we are using nowadays for brace building the idea in the sagittal design, the idea of the relationship with the spinal geometry and the pelvic indexes. This is very important to get a good sagittal balance. So braces like this, which allow the patient to stand balanced with a good sagittal profile, a physiological sagittal profile, are very different to these other braces which present an inverted sagittal geometry and a clear anterior imbalance. This is something we have to avoid totally. Now, when you have a double structural curvature, which are primary, so both curvatures are primary, thoracic and lumbar, orthoracolumbar, then you will need to apply the same mechanism for the thoracic curvature, but also a similar mechanism for the lumbar thoracolumbar curvature, meaning regional derotation together with a 3-point system to decollapse the concavity. And also the fact that here the dorsal contact that you are providing together with the lateral force is an integrate pad which is working obliquely in the plane of maximum deformity in order to get the best possible frontal plane alignment together with the best possible lordotization of a spine which tends to kyphotize in the lumbar orthoracolumbar region. So at the end of the day, you have here enunciated the principles of this concept. The first step is to produce a pre-elongation and 3D alignment. Then we design regional derotation or derotations, depending on whether you have single thoracic curvature or lumbar orthoracolumbar or double structural. Then you need caudal and cranial counter-rotation forces. Then you need the 3-point system guiding frontal plane alignment. So you don't get the frontal plane correction through this 3-point system. This is just to guarantee a correct frontal plane alignment. Then you use the proper sagittal plane profile and balance, and a proper shape and orientation of the contact areas, especially in the thorax, to remodel or to reshape the thorax to fight against the lordotization. Finally, we can, in the brace construction, we can explain the orthotis classification, which is facilitating the brace construction in terms of predefined strategies of correction. This classification that I have been using for many years is not really a new radiological classification. It's nothing related to that. Of course, we cannot use the Lenke classification for bracing because Lenke classification is to define the extension of the fusion and is used in major scoliosis. You cannot use Lenke classification in mild scoliosis because the criteria that you use to define objectively the type of Lenke is not possible to do it in mild scoliosis. So we had to do something different. And starting from the 3-4 type of scoliosis described first by Catherine Roth and then by Jacques Chenou, we were paying attention on that these types are functional types or clinical types based on the presence of a structural curvature in one or more than one regions, could be thoracic, lumbar, proximal thoracic, and then the global frontal plane imbalance. So that way, when we have structural curvature at the thoracic region with no lumbar structural curvature or with a functional or mildly structural lumbar curvature, and global imbalance goes that way, the trunk is translated to the convex thoracic side, we talk about an A type. When we have double structural, more or less the same double major or major lumbar thoracolumbar minor thoracic curvature, and we have global imbalance to the convex lumbar or thoracolumbar side or to the concave thoracic side. So it goes different to this. For right thoracic scoliosis, this is imbalance to the convexity of this major curve. And in this case, the imbalance goes to the convexity of the major curve, being the major curve in this case, or the driver, the lumbar or thoracolumbar scoliosis. So this is the B type. Then you have thoracic scoliosis with functional lumbar or with a structural mild secondary lumbar scoliosis, which are totally balanced. And then you have the case of the single lumbar or thoracolumbar. This is called Z, and the single lumbar thoracolumbar is called E type. I cannot go really deep on this because the time is out. So the only thing I can say is that we use here, observing the trunk using the concept from Roth about defining different regions. These regions, depending on the curve pattern, are deviated, rotated, and deformed in a particular way, deviated and rotated always to the same side, and then collapsing on the concavity and expanding on the convexity. And in A type, so when you observe thoracic scoliosis with the transitional point imbalance to the convex thoracic side, depending on how long is the curvature, if you have a long curvature going down into lumbar with some conditions, you define this as an A1 type, and then you define A2 type. This is the single thoracic with no lumbar or functional lumbar. And then the A3 is the structural thoracic, a major thoracic with a minor secondary structural lumbar curve. And the same, you have the B type. B type is double structural. Usually the lumbar thoracolumbar is major, or they can be double major, and much less usual. This is an atypical case. Thoracic could be the major curve. And in this case, you have the transitional point between thoracic and lumbar imbalance to the concave thoracic side according to the central sacral line. This is called B type. And you have B1 for lumbar and low thoracolumbar apex at T1. And you say only B2 when you have the apex of the thoracolumbar curvature at T12. So according to this, you have a schema of blocks for every type of scoliosis, every clinical type, the A type with the 3 subgroups, A1, 2, 3, then the B type with the 2 subgroups, B1, B2, then you have the C type, which are balanced, and you have a C1 and C2 depending on whether you have lumbar structural curvature or not. So you say C2 only when you have lumbar structural curvature, but in both cases, the balance of the transitional points at T1 is irrelevant. And then you have the E type, which is like B, but without thoracic scoliosis. You were, my previous speaker was presenting a case of surgery fusing only the thoracolumbar curvature and then developing a thoracic curvature. This is because there was, in some cases, you have, which is not noticeable on the X-ray, a hidden structural curvature in the thoracic region, and if you use only correction for the lumbar thoracolumbar, and you forget about this, then this hidden thoracic structural curvature can develop and progress. So it's important to look at the patient, not only at the X-ray, because sometimes on the X-ray, this curvature is invisible. You cannot see that. It's a hidden curvature. But on the exploration in the Adam test, you have a clear structural thoracic curvature. And in those cases, you will need to use braces according to the B type, meaning long braces, because E type is the case we use a short brace. We have produced an algorithm starting in the clinical assessment. So in the clinical assessment, we can already say which is the type of scoliosis we have. And then we have a radiological correspondence based on the position of the transitional point, the curve pattern according to the SRS nomenclature, and some differentiations between some criteria to differentiate well the A1 type to the A2 and A3 type. And for all of these type of curvatures, you have a specific design which is well described and a specific technique to produce this type of brace. And you see how the same name can be different in the aspect depending on the curve pattern. Okay, so you have here the A-type brace, you have the A2 and A3, then you have here the A1 brace, which has the pelvis open on the right side, on the convex thoracic side. Then you have the B1, which has the pelvis open in the concave thoracic side, the opposite to this, to allow the pelvis translation right to left or right thoracic, left lumbar. Then you have the C type, which is balanced. You can have it open for C2, or you can have it closed pelvis for C1. And this is the E1-2 brace, which is a short brace to act specifically and only on the lumbar thoracolumbar curvature. So all of these are braces under the same name, but the design is totally different. So the message to take home is that the current evidence supports the need of treatment, non-surgical and operative, paying attention to the radiological values, but also to the patient perspective, following a biopsychosocial model. 3D brace design following Rigo-Chenur principles can offer good balance in the frontal plane through the torsional mechanisms, and with when designed correctly, with a correct sagittal profile and implementing a detorsional mechanism, which is not too much more than the scoliosis can accept, then you can control also the sagittal plane geometry and balance. So maintaining the previously normal sagittal geometry in the lateral X-ray, meaning the geometry of the spine, no matter which is the amount of lordotization you have, looking at the plane of maximum deformity, many scoliosis with relevant lordotization presents a paradoxically normal or hyperkyphotic geometry in the middle sagittal plane. So if you have a correct sagittal geometry in the middle sagittal plane, try to maintain this by using the brace, not to deteriorate that, and look for a partial restoring if you have a more relevant flat back. These would be the objectives, but as a whole, this brace construction also supported by a specific classification and blueprints remains highly intuitive and depends very much on the clinical experience of the brace maker. So education is a very important point here. We need orthotists with better knowledge about the 3D nature of scoliosis and about which are the real objectives of the brace treatment. So as a whole, this 3D brace concept, according to Rigo Chenur principle, is not really an orthopedic product. It's nothing working just because you put a name in your prescription, but it's a concept, complex concept like scoliosis is. So looking at its current standard and risk of iatrogenic, we really don't recommend its general use, but only its use by experienced team, educated and with good experience, all the members of the team, the doctors who are going to prescribe and to control the brace action, the orthotists and also the physiotherapists are an important part of the team because they can follow very close the patient session by session and observe whether patients tend to present iatrogenic effects or not. So besides the undesirable effects that my previous speaker was talking about, I am very concerned about the iatrogenic of bracing. Like you have the iatrogenic in surgery. It's not so easy like it looks sometimes. Okay, you know that you need to be an experienced surgeon to operate well scoliosis and to make correct decision. And it's the same for bracing. Also, it's not so relevant. You don't go into the body. You don't have so risk like when performing surgery. But the principle of corrections are the same, with the only difference that in surgery, you apply your forces directly on the spine. And in bracing, and I would say this is even more complex, you apply the forces in the trunk, in the deformed trunk. So you have to reshape the spine by reshaping the body. That's the point. A brace which is producing secondary trunk deformity is not working good. It's not working specifically. The only way you can really get a good result in the long term is by reshaping the best you can the spine, but also reshaping the trunk. Better the trunk is reshaped, longer will be the effect of the brace because this is giving stability to any result that you have. Okay, so that's all. Thank you very much, and apologize if I was a little bit out of the time. Thank you very much.
Thank you very much. Are there any questions? So, Dr. Rigo, in a patient who's obese, can it be done, or it's a contraindication?
Sorry, I didn't understand the question well. Sorry.
No, obese patient, a patient, with obesity,
Obese.
or yeah. So would you?
Yeah, obesity.
Would it be a contraindication?
The obesity is a limitation, as well as low BMI. This is also a limitation. Low BMI because this is normally a sign of bad response, and obesity because the forces that you need to implement are hardly reaching the spine when the trunk is very big. Okay, so obesity is a clear limitation for bracing. Still, you have obese patients that are very compliant, that with a good brace, but not correction of 50%, they can stabilize the curvature. So
Dr. Nene has a question. Thank you.
You're welcome.
Great talk, Dr. Rigo. Is
I-
there any role for bracing using the Rigo brace in non-idiopathic scoliosis, like syndromic or really congenital or even early onset?
Yeah, theoretically, I would say that secondary neurological scoliosis, according to the Castellan studies, are also following a torsional mechanisms, comes from a torsional mechanisms with lateral deviation, rotation, and lordotization are coupled. But the point is that used to be at the beginning more flexible curvatures, and these are type of curvatures that you can treat well through the 3-point system from lateral pressures. Okay, the torsional phenomenon is not so, let's say, dramatic like in some potentially high risk for progression idiopathic scoliosis. Okay, syndromic is also a limitation because the structural deformity, the intravertebral torsion in syndromic scoliosis is much more, like in patients with low BMI and also with some degree of vitamin D insufficient on deficiency, where the bones are much more reshaping by the external forces. So these curvatures becomes structural and rigid and difficult to correct very early. So this is bad prognosis. From my point of view, treating syndromic scoliosis with a brace is something you have to do because sometimes you need to buy time before you can perform surgery. But most of them, if they are really progressive, are condemned to probably surgery.
And what's your follow-up protocol? How often do you do the X-rays?
It depends on the patient. Normally, when I have a patient on the full-time regime in the brace, I don't do classical X-ray out of the brace at 6 months if the in-brace correction and the compliance is good. If the in-brace correction and compliance are good, and at 6 months, using external exploration by using a scoliometer and surface topography, the situation looks like control, then I don't order the out-of-brace X-ray at that time, but 1 year later. However, for all the patients using partial time bracing, so no reaching 18 hours, or nighttime bracing, I think it's obligatory to make the X-ray out of brace every 6 months. Yeah, so it's between 6 months and 1 year, depending on the response on bracing and the wearing time. This is my usual protocol. And this is
when do you
following
stop
the
the brace?
recommendations of the SRS, yeah.
And when would you stop the brace? So will you full time, then partial, weaning, and then stopping? How would you decide that?
I go from full time to partial time. Partial time, depending on whether the season of the year you are. I maintain partial time 3 to 6 months. So if I am very close to the summertime, I do it only 3 months. And if I am in the winter, I recommend 6 months. And then making out-of-brace X-ray. And if the situation is still controlled, passing to nighttime for a year. 6 months to a year, also depending on the season of the year.
And in case you need to change the brace, how often do you need to change the brace?
Oh, this is depend on the growth velocity. I mean, I have used sometimes in early onset scoliosis the same brace for 2 or 3 years with no need to change, just doing little adjustments in the length, especially by modifying the upper point. And in adolescence, passing the peak of growth very close to the menarche, maybe the brace is dead in 10 months, 1 year. So it depends on the time. When I make a brace and the girl is normally in the first years after menarche, if I make the brace with an elongation enough and with a space enough, this used to be a unique brace, the brace that the patient can wear till the end. But if you make the brace before menarche and with the patient passing the peak of growth, normally you will need to remake the brace or make a new brace 10 to 12 months later. Yeah.
Thank you. Thank you very much. Both the talks are enlightening. I'll hand it over to Dr. Riday. Thank you.
You're welcome.
Thank you so much, Dr. Rigo, Dr. Menon, for a wonderful talk. This has been something which would expand our indications of bracing and also help our orthotic colleagues to make braces in a better way. Hope to see you soon, Dr. Rigo. I'll also like to thank JESCO, our industry partners. So before we move on, our next session is from bracing. We move on to the most talked about surgical technique in scoliosis these days, that's tethering, the role of vertebral body tethering in scoliosis. And this will be on the first Thursday post Diwali, that is the 7th of November. So hope to see you all there. I'd like to thank our audience for being there, all the Pediatric Spine Academy committee members, Dr. Rigo, Rebecca and Gary. Thank you so much. Hope to see you all again. Thank you so much. Namaste.
Namaste.